Yeah, very good evening, dear my professional colleagues, and thank you, Chaitanya, for your kind introduction. And this is Dr. Sepuri Krishna Mohan. I'm an endocrinologist at my own center, Sepuri Diabetes and Endocrine Center, Karnool. And thanks, Dr. Reddy's people, for giving me the opportunity to be the speaker of this evening for this webinar today. And today we are going to talk about the role of SGLT2 inhibitors in heart failure. Per se, uh, it's a cardiologist topic actually. So the speaker should be a cardiologist. But they asked me to talk about the heart failure and the role of the SGLT2 inhibitors, per se, the dapagliflozin actually. So let's transform ourselves from the domain, endocrine domain, to the cardiology domain today for a change. So let us see. You all know the basics of the heart failure and the role of dapagliflozin in the treatment of the medical management of the heart failure. Let's dive deep into the subject with all the references and the evidence-based medicine. So let me just take a few moments to have an introductory session so about two things. The first thing is about the SGLT2 inhibitors, and the second thing about the heart failure. Let's talk about the history of the basics of the SGLT2 inhibitors, and so also the basics and the historic importance of heart failure. So the US FDA has given approval for the dapagliflozin, the molecule which belongs to the SGLT2 inhibitors, which are called the gliflozins, way back in 2014 actually. So it's more than a decade the US FDA has given approval for dapagliflozin, and we know how it acts. It acts through the kidneys. Actually, the SGLT2 inhibitors are the novel sugar lowering drugs which act through the kidneys at the level of the SGLT2 receptors are present at the level of the proximal convoluted tubules. So the inhibition of SGLT2 is going to have the multiple benefits, like the reabsorption. It's going to prevent the reabsorption of the glucose from the urine, and the glucose is being excreted through the urine. So there is calorie loss and there is weight loss, so which results in the lowering of blood glucose as well as the lowering of the blood pressure. And it has got the additional advantages, like it reduces the weight very significantly, which is a very desirable effect with regards to the obese type 2 diabetes or overweight type 2 diabetes people. And later on, they declared to me 58 when it rolled out the cardiovascular outcome trial, the first cardiovascular outcome trial for this particular dapagliflozin. They declared to me 58. So we just thought it's a mere glucose lowering agent, and we thought when canagliflozin was approved in way back in 2013, and when empagliflozin was just in the middle, in between cana and dapa, there is empagliflozin. In the first quarter of 2014, the US FDA gave approval of empagliflozin, and we all thought these are the best glucose lowering agents in terms of the reductions in the fasting plasma glucose and the postprandial plasma glucose and the HbA1c. And later on we came to know that these drugs are going to act on the blood pressure by reducing a significant reductions in the systolic blood pressure, and a nominal reductions like 2 to 3 millimeters of mercury of diastolic blood pressures, thereby reducing the blood pressure round the clock 24 by 7, that is daytime, the evening, and the nocturnal blood pressure. Thereby the nocturnal hypertension, it's a very good add-on therapy to the standard therapy of the nocturnal hypertension or the resistant hypertension or per se the hypertension. So later on we came to know that after the DAPA HF and the DAPA CKD, we just came to know that the dapagliflozin has got the very beneficial effects on the cardiovascular system in reducing the events of the 3-point MACE, and as well as the heart failure and the hospitalization for heart failure. And later on we just came to know that the DAPA CKD was done, and the evidence-based medicine shows that it also reduces the deterioration of the kidney function by improving the estimated glomerular filtration rate, and later on the positive effects on the liver also in cases of the non-alcoholic fatty liver disease or the alcoholic fatty liver disease or the non-alcoholic steatohepatitis or the alcoholic steatohepatitis. But once the patient moves on to the scarring stage, that is stage of fibrosis, that is cirrhosis, and we don't have any role to play with that. Cirrhosis is the penultimate stage, and it progresses to the hepatocellular carcinoma. So this is about the dapagliflozin, and we have got SGLT1 receptors also. This is the sodium glucose co-transporter receptor 1, which are present in the proximal straight tubule. The SGLT2 receptors in the PCT, and these are present in the proximal straight tubule, that is PST. So there is a molecule called sotagliflozin which acts on the both the SGLT2 1 inhibition and SGLT2 inhibition. So this has got the added advantage of the complete blockade, that is the total blockade of SGLT1 receptors as well as the SGLT2 receptors. So per se we have got 3 US FDA approved gliflozins in our country, that is they start with canagliflozin, empagliflozin and dapagliflozin. Now the everybody is impressed with the results with this particular the empagliflozin is showing and the dapagliflozin is showing with regards to the cardiovascular outcomes, with regards to the renal outcomes, with regards to the hepatic outcomes. So with seeing the overwhelming response, the US FDA for the first time, I think, it has given approval for these two molecules, the empagliflozin and the dapagliflozin, to be used in the heart failure patients in the absence of diabetes. That is the take-home message actually. So even in the absence of type 2 diabetes mellitus, the cardiologists are liberally using this particular the empagliflozin and the dapagliflozin in the cases of the heart failure. So this is the one the greatest added advantage these molecules have earned. It's a great honor for these two molecules to be endorsed by US FDA for usage even in the absence of type 2 diabetes mellitus. And let's come to this heart failure. Okay, see, everybody knows what heart failure is. So there is some sort of imbalance between the demand and supply. The body requires so much of blood, oxygenated blood. The heart is not able to. It doesn't mean that the heart has stopped or something else has happened. Nothing has happened, but the thing is, the heart is not able to pump very effectively. The cardiac muscle per se, the left ventricle is not able to pump very efficiently to meet the demands of the oxygenated blood for the body. That is the general definition of heart failure. And we have got some landmark uh, definitions for this molecule. And first of all, it was Sir Thomas Lewis who described about heart failure. He said a condition in which the heart fails to discharge its contents adequately. He said it in 1933 actually. It's a great honor that he said it in 1933 when nothing was known. And he also said that the very essence of the cardiovascular practice is the early detection of heart failure. He added, Sir Thomas Lewis. And later on, a good definition was given by Paul Wood, Dr. Paul Wood in 1950. He said it's a state in which the heart fails to maintain an adequate circulation for the needs of the body despite a satisfactory filling pressure actually. So these are the old definitions actually, but they still hold good as on today also. And coming to this particular the history of heart failure, so it's mentioned even before the common era, that is in the ancient times also, the Indians, the Indian physician Charaka and Sushruta, in Charaka Samhita and in Sushruta Samhita, they have mentioned about the heart failure. And the ancient Greeks have mentioned, and the ancient Romans have mentioned. So also the ancient Egyptians also mentioned about this heart failure. So the landmark, the history has got some landmark milestones in case of the heart failure. That is which started with the first one. It was very vague actually until William Harvey described about the circulation in 1628 actually. He is the first one. You all know that William Harvey is the one who described about the human blood circulation and heart in 1928. Until then it was not clear, the heart failure or even the heart diseases also. And after that, the William Withering in 1785 published an account of the medical uses of digitalis actually, the digoxin, what we used to use. And in 1819 actually, Rene van Lennep, he is the one who invented our stethoscope. Say after the invention of this particular stethoscope only, so we came to know what auscultation is. And followed by Jan Thoven in 1890, who discovered this the electrocardiography, the ECG. And in 1895, William Röntgen, who discovered the X-rays, which made the diagnosis a little bit easy. And the 1920, the diuretics were first used actually. And in 1954, the Inch, Edler and Helmuth Hayes used ultrasound to image the cardiac structures. And way back in 1958, the diuretics were introduced. And 1967, the Christian Bernard performed the first human transplant actually. And the landmark trial, that is the Consensus 1 study that showed unequivocal survival benefit of the angiotensin converting enzyme inhibitors in the severe heart failure. And the molecule that was used is enalapril for the first time. The Consensus 1 study is the first cooperative North Scandinavian enalapril survival study, which was published in way back in 1987, showed the unequivocal survival benefits of enalapril in patients with severe heart failure. See, this is the some history of this particular heart failure. And then this is the disclaimer coming into the topic. And today we are going to discuss about the evidence-based role of dapagliflozin with the dedicated studies with regards to heart failure. And today's table of content is divided into the epidemiology of heart failure in India, the guideline-based management of heart failure, and the beneficial effects of the SGLT2 inhibitors in heart failure, and per se about dapagliflozin, the recent clinical updates in the heart failure, and the studies which are in pipeline with regards to heart failure, and last is the summary, the take-home message actually. So let us see this slide, the very, very busy slide. This shows the profile of an Indian patient with heart failure. See, why heart failure in Indians is so different? Like diabetes, like heart attacks, because like diabetes, the specific the one peculiarity we find in Indian scenario is that we see this the incidence, the prevalence, it comes 10 to 20 years early when compared to the Caucasians. So that is how the diabetes is so different, and the insulin resistance predominates in our Indian population, whereas insulinopenia predominates in the Caucasians. So some characteristic features are very unique to our Indian population, usually called the South Asian population. See, our scenario is described as Indian scenario is described as South Asian scenario. So in this way, the profile of an Indian patient with heart failure is also very atypical when compared to the heart failure of the Caucasian. So the Asian heart failure registry, including the participants with symptomatic heart failure, the South Asia was represented by India. See the points, the patients with HREF, that is called the heart failure with reduced ejection fraction, were younger than the patients with heart failure HPF, that is heart failure with preserved ejection fraction. So before going to this, I just have to, everybody should have a glance about the classification of the heart failures. There are multiple classifications in heart failure. The gold standard is, you all know that, NYHA, that is New York Heart Association classification, based on the functional component of the heart, based on the symptoms of the patient. See, New York Heart Association, NYHA, has the Roman 1, 2, 3, 4. 4 is the worst, that is like end stage renal disease. 4 is the end stage heart failure, dead end stage of heart failure, and 1 is asymptomatic, and 2, 3 are in between. This is the gold standard, we know that from the beginning. And there is another classification by this the American College of Cardiology Foundation, and in association with the American Heart Association, and with this particular the Association of Heart Failure of America. They have a joint consensus classification which classifies into 4 stages, same like NYHA 1, 2, 3, 4. This is ABCD actually, depending upon the structure of the myocardium. And the latest classification being that is based on the ejection fraction, the left ventricular ejection fraction, LVEF. So when we send the patient for 2D echograph, the cardiologist or the cardiographer, they give the ejection fraction like 65 or 60, 50, 40, 35, 20. So based on that, there are certain terminologies, like the first one is, see, anything above 60, anything of left ventricular ejection fraction above 60 is called normal, and there is a term called the heart failure with preserved ejection fraction. So that is the left ventricular ejection fraction from 50 to 59 is called percent of LVEF is called the heart failure with preserved ejection fraction. And there is a term called the heart failure with mildly reduced ejection fraction. That is the left ventricular ejection fraction from 41 to 49. So 50 to 59 is the heart failure with preserved ejection fraction, that is called HPF. This is called 41 to 49% of LVEF is called heart failure with mildly reduced heart failure. And anything around 40 or below 40 is called the reduced, that is called HRF, that is heart failure with reduced ejection fraction. So as the score goes down, the severity of the disease increases. So reduced ejection fraction has got a poor morbidity and poor the outcomes, like the high morbidity and high mortality rates when compared to the HPF people, that is heart failure with preserved ejection fraction. And the intermediate, that is the mildly reduced heart failure, has got a better prognosis when compared to the HRF, that is heart failure with reduced ejection fraction. So this determines, this is a reasonable and a rational and a very logical classification as on today, so that we can the guideline mediated, the guideline directed medical therapy can be initiated. And one thing I would like to let you know that see, heart failure only is a curable condition. It's never a curable condition. It's only a treatable condition. See, it can never be cured. There is no permanent cure for heart failure. It has got two components: the medical management and the interventional management. So interventional management is done only when the patient has become very critical. Usually we start this the CRT, that is cardiac resynchronization therapy, with in cases of the HRF, that is the patients where the left ventricular ejection fraction is around or below 40%. So that is cardiac resynchronization therapy. And there are again the different modalities. This CRTP is called where you implant a pacemaker, and there is a term called D also, where there is the cardiac resynchronization therapy with a defibrillator. And these are the terms we have in this particular. And the ICD, what we call is the implantable cardioverter defibrillation. These are the interventional modalities of management of heart failure. And today we are pertained to the medical management of heart failure. So with this, I think you have no confusion. And there is one more component called the heart failure with improved ejection fraction. That is where the patient should be like in the stage of HRF, that is the left ventricular ejection fraction should be less than 40 or less than 40, and with the treatment, with either with the dapagliflozin or with the beta blocker or with the AC inhibitor or the ARBs or with the RNA or the MRAs, where the patient improves his ejection fraction, his or her ejection fraction, to a tune of at least 10 points. The patient, if it is like 38% of ejection fraction, and after the treatment at the end of 1 year or 2 years, the patient improves to like 48% of ejection fraction, it is called it is defined as the heart failure with improved ejection fraction. So with this, so the patients with HRF are younger than the patients with HPF. This is the peculiar feature of the Indian patient. Among the patients with the heart failure with reduced ejection fraction, older cohorts were more likely to be female. Approximately half of the patients with the heart failure with preserved ejection fraction were women. Duration of heart failure was longer in HRF. Ischemic etiology of heart failure was more common in HRF. And high prevalence of diabetes mellitus and stroke, hypertension and CKD and the coronary artery disease. So per se there are two causes for heart failure, the major causes. I am talking about the major causes. The one is the coronary artery disease and the second is the long standing hypertension. So don't take hypertension so easy that every time I say ABC, see, not only the control of blood sugar, the control of meticulous control of blood pressure is equally important, and the cholesterol also is very important. A for A1C, B for blood pressure, C for cholesterol. And the other classification which I forgot to mention is like it's left ventricular heart failure and the right ventricular heart failure, that is left-sided heart failure and right-sided heart failure. Most often what we see is called the left-sided heart failure, where the left ventricle is not able to pump effectively to send the oxygenated blood through the aorta to the entire body. That is called the congestive heart failure. Whereas right ventricular failure, right-sided failure usually is associated with the lung causes, and it is called the car pulmonale actually. So coming to the right hand side, it's a table given. So you can see the multiple factors, the age, the females, the NYHA class 3 or 4, the body mass index, and the EGFR, duration of HF. Is it less than 1 year or 1 to 5 years, 5 to 10 years, more than 10 years? Because if we classify like this, the prognosis can be predicted actually. The prognosis of less than 1 year heart failure has got a better prognosis when compared with the heart failure of more the duration around or more than 10 years. So if we see this, the overall and the third one is the HRF, that is heart failure with the reduced ejection fraction, and the fourth one is the heart failure with the preserved ejection fraction. If we take the number actually, you can see how dominant the heart failure with reduced ejection fraction in our Indian scenario. The total number is 1688, out of which 1436 are with reduced ejection fraction, that is HRF, and 252 are HPF. And age you take, the overall age is the 59 years and the HRF is 58.3, the mean age, and the mean age of the HRF is 63. That's what we said is proving to be very true. The inference is drawn from this study only, that is the Asian HF registry actually. So the females, they 467, and out of which 349 they belong to HRF, and 118 they belong to HPF. And New York Heart Association classification 3 and 4, the overall number is 499, and the respectively the 454 and 45 respectively, and the body mass index is also like the 25 the is for HRF, whereas 28. So even the less overweight, the less obese people had HRF. So if you take like this, even the duration also, the HRF dominates in all the factors like the ischemic etiology, the coronary artery disease, the atrial fibrillation, the hypertension, the prior stroke, the peripheral arterial disease, or the COPD, or the diabetes mellitus, or the renal artery stenosis, or the CKD. See, the peculiar aspect is HRF predominates HF in Indian scenario. And this slide shows that the heart failure carries a high mortality rate in Indian scenario, and the international congestive heart failure, that is inter-CHF prospective cohort study, said that the Indian population has got whereas with regards to outpatient scenario it is 4.1, and inpatient scenario it is 2.4 times higher risk of mortality compared to the South Americans. So when you see this graphic representation on the right hand side, you can see the adjusted survival curves by the region. This is adjusted with South America as the reference. The first year mortality in India was 1.9 versus 4.3. The South America was 1.9, whereas the mortality rate in India was 4.3 with a the hazard ratio of 2.9 and with a confidence interval of 95% actually. So when you see the p-values, actually you can see the p-values. The China, it is 0.1402, which is not significant statistically. India with less than 0.0001, that is statistically very significant, and Southeast Asia also is very statistically significant, and Middle East, that is the Gulf and all, it is 0.2349, that is statistically not significant, that is mortality and morbidity are low when compared to the Indian population and the other the Southeast Asia population. And when taken the African population, that is also similar to that of India. The mortality and morbidity rate is similar to that of India, maybe because of the poverty or the available medical facilities, maybe. So this slide shows the guideline directed management of HF. So on the left hand side you can see that the European Society of Cardiology, he said actually, so a rapid introduction of the foundational 4 pillars at the low doses to introduce cardiovascular mortality and morbidity, which in turn reduces the incidence of heart failure and the hospitalization for heart failure, and again is going to they protect the kidney. So the heart is protected and the kidney is protected with the foundational 4 pillars of the management. See the 4 pillars, what we see is, the first one is the SGLT2 inhibitor. It is SGLT2 inhibitor means only the empagliflozin and dapagliflozin only. That is 25 mg of empagliflozin and 10 mg of dapagliflozin. And the RNA, that is angiotensin receptor, and the neprilysin inhibitor, that is called the combination of angiotensin receptor blocker and a combination of neprilysin inhibitor, that is called the sacubitril, and the combination of valsartan. The sacubitril is neprilysin inhibitor, whereas the valsartan is NARB. And coming to beta blockers, so, and the last one is the mineralocorticoid receptor antagonist, that too the specific term is called the non-steroidal mineralocorticoid receptor antagonist, that is especially the spironolactone, the eplerenone. The dosage should not exceed 50 mg per day, and the last one which is picking up is the last non-steroidal, the mineralocorticoid receptor antagonist is nowadays finerenone, which is being investigated and thoroughly studied, and the results are proving to be much superior when compared to the spironolactone and eplerenone in the treatment of the heart failure as well as the kidney disease also. So these are the 4 foundational 4 pillars, that is SGLT2 inhibitors and the RNA and the beta blockers and the this particular the mineralocorticoid receptor antagonist. So come to the let us see the evidence. The key update of the European Society of Cardiology 2023 guidelines and the American College of Cardiology and the American Heart Association and Heart Failure Society of America 2022 guidelines, what they say, the addition of SGLT2 inhibitors across the spectrum of HF has got a big advantage. That is the core message. You can see the table is classified the stage of HF and the recommendation and the COR, that is class of recommendation. The stage stage A heart failure is at risk of heart failure, and stage C is symptomatic heart failure actually. And stage CHF is this is diagnosable and advanced enough to cause symptoms like cough, shortness of breath, that is dyspnea and exertion, and the fatigue and the swelling of the feet and leg. This is type C heart failure. And the first one has got the recommendation to prevent heart failure hospitalization in patients with type 2 diabetes who have cardiovascular disease or at high risk for CVD. The class of recommendation is 1, that is the highest recommendation. And coming to this the second one, the heart failure with reduced ejection fraction, the recommendation is the class of recommendation is 1. And to reduce the heart failure hospitalization and to reduce the cardiovascular mortality in patients with symptomatic chronic heart failure with reduced ejection fraction regardless of the presence of type 2 diabetes. And coming to the third part, that is heart failure with preserved ejection fraction, an SGLT2 inhibitor, dapagliflozin or empagliflozin, is recommended in patients with heart failure with preserved ejection fraction to reduce the risk of heart failure hospitalizations or the cardiovascular death. The class of recommendation is 1A. Coming to this, I said the heart failure with mildly reduced ejection fraction, that is the left ventricular ejection fraction being in between 41 to 49% of LVEF. An SGLT2 inhibitor, dapagliflozin or empagliflozin, is recommended in patients with heart failure with mildly reduced ejection fraction to reduce the risk of heart failure hospitalization or the cardiovascular death. That is also classified as the 1A. So now this slide shows the treatment algorithm for medical therapy in the patients suffering from the heart failure with preserved ejection fraction. So the treatment of this heart failure with preserved ejection fraction, according to the 2023 American College of Cardiology expert consensus division pathway, it is SGLT2 should be added, and the SGLT2 inhibitor should be initiated in all HPF patients. All patients suffering from the heart failure with preserved ejection fraction, the addition of SGLT2 inhibitor, either the dapagliflozin 10 mg or the empagliflozin 25 mg, is mandatory without contraindications. If at all it has got some contraindications, but for that, and you can, and ideally once stable during hospitalization for index event. So every patient suffering from the heart failure with preserved ejection fraction should be put on this particular dapagliflozin or the empagliflozin according to the 2023 guidelines given by the American College of Cardiology expert consensus decision pathway. So, and the treatment for this heart failure with preserved ejection fraction is by adding the SGLT2 inhibitors, and again it is divided into 4 classes actually. So the first class is the for individuals with fluid retention, that is New York Heart Association classification, that is class 3 to 4. You need to titrate and you can add a loop diuretic agent. Coming to the second segment, for women with all ejection fractions, and for men with ejection fraction less than 55 to 60%, Those with the fluid retention add the non-steroidal mineralocorticoid receptor antagonist, the spironolactone 50 milligram, or the eplerenone, or the finerenone. And coming to the third component for women of all ejection fractions, and men with left ventricular ejection fraction around 55 to 60, add ARNI. ARNI is nothing but, I said, it is angiotensin receptor and neprilysin inhibition, that is the inhibitors. The main component being the sacubitril and the valsartan. So we see, after the emergence of this the ARNI, which got the US FDA approval in 2015, after the gliflozins were approved, 2013 and 2014 were the years where the canagliflozin and empagliflozin, dapagliflozin were given approval by the US FDA, and later on it gave the approval for the ARNI in 2015 actually. So after the ARNI came into the scenario, there is a drastic change in the medical management of heart failure. See, the patient started improving drastically with ARNI, that is sacubitril and valsartan. So we usually, there are 3 doses available, the sacubitril plus valsartan, and it is 50, 100 and 200. So the 50 has got 24 milligram of sacubitril and 26 milligram of valsartan. Likewise, you take the ARNI 100, it is the 49 is the sacubitril and 51 is the valsartan. And if you take the 200, it is 97 milligram of sacubitril and 103 milligram of valsartan. As of now, the US FDA has given approval only to this particular valsartan. The ARB selected is valsartan along with the sacubitril. So depending upon the condition, what we is generally in the mildly reduced ejection fraction or the heart failure with preserved ejection fraction, we add this ARNI. Generally we start with 100 milligram of ARNI, that is what I said, the 49 milligram of the sacubitril and 51 milligram of valsartan twice a day for 2 to 4 weeks. Then we uptitrate if the patient has no problems, no side effects, like the angioedema is the one the side effect of valsartan, you should keep it in mind. So if the patient has got no problems and after 2 to 4 weeks, based on the improvement, we uptitrate to 200 milligram twice daily, and we need to maintain the dose and they titrate the dose. This is regarding the ARNI. And the last one, for all for ARNI eligible individuals who cannot take due to the cost or the intolerance. See, earlier before the US FDA gave approval to this ARNI, we used to use either ACE inhibitor or ARB along with the beta blockers, along with the mineralocorticoid receptor antagonists. See, these were the ones. This is the first one I said. The enalapril was the first molecule to be used in the heart failure very, very early in we mentioned it in the history of the heart failure. So to start with enalapril to captopril to all the prils, the ramipril, all the prils are the ACE inhibitors, or the all sartans, the losartan, until the valsartan, irbesartan, candesartan, or the telmisartan, or the vormisartan, all sartans, the azilsartan being the latest one, which we have it in India, though not proved to be so effective. So the sartans are ARBs, the prils are ACE inhibitors, but never ever try to combine both. No ACE plus ARB, which has got the hazardous side effects on the kidney, which may lead to fulminant, that is sudden kidney failure because of hyperkalemia, So never ever try to mix these two molecules. So the patients earlier to RNA were on either ACE inhibitor or ARBs. So RNA was in the initial period, it is a research molecule of the Novartis. The brand name is Vimada actually. So it was so costly that not able to, all the patients were not able to afford to go for the Vimada, the brand of Arni. So they were already on either ACE inhibitor or ARBs. You know the commonest side effect of ACE inhibitor being the very distressing, disturbing, nagging dry cough is the side effect of with the all ACE inhibitors. So that is the only the biggest barrier which in the rat race of the AC inhibitors and the ARBs, it is trailing behind. The AC inhibitors are trailing behind when compared to this head-to-head fight with the ARBs, just because of its the undesirable the continuous dry nagging cough. So those patients, when they were changed to RNA, they were much better, and they were rid of this side effect. And also, so the all certains, they have some sort of URI, or sometimes they have got the angioedema, the laryngeal edema as side effect. Very rarely seen so far. I have never seen with any certain, but still in this particular the patients who are on ACE inhibitors or ARBs may be not able to purchase the Vimada, the brand of RNA. This is the fourth classification. So if the patient is on ACE inhibitor, you try to add one ARB instead of ACE inhibitor. ARBs are proven to be much better when compared to this the ACE inhibitors. So the ARBs have got a better antihypertensive effect. They reduce the blood pressure very steadily and very significantly, and a true 24-hour molecules. And the greatest advantage of the combination of the RNA with this particular that is the sacubitril with the valsartan is the valsartan reduces the pressure, which is much required in patients suffering from heart failure, and also the sacubitril also has got the advantages of that it gets rid of the sodium from the body, which is a very desirable effect which is seen with sacubitril. When the sodium is excreted from the body, the fluid also goes along with the sodium. So there is lessened volume overload with this particular the sacubitril, and also the patient tends to pee a lot. That is, he passes a lot of urine with sacubitril, which is a very desirable effect actually. And the inference is the SGLT2 inhibitor, that is dapagliflozin or empagliflozin, has class 1A recommendation to reduce the risk of heart failure, hospitalization or cardiovascular death. And this is a very busy slide showing SGLT2s are promising therapeutic agents for heart failure. Absolutely, it is true. The evidence medicine shows that the two subpopulations, that is where the left ventricular ejection fraction is more than 40%, that is broadly classified as HPF, and the second population is HRF, that is the left ventricular ejection fraction is around or less than 40%. And the SGLT2 inhibitors showed benefits across the spectrum of ejection fraction, with reductions in the composite endpoint of the cardiovascular death or hospitalization for heart failure in the range of 21 to 25%, and for the reduction of hospitalization for heart failure in the range of 26 to 31% actually. So move on to the next slide. Here we see a case presentation. A 64-year-old male patient presents for a follow-up visit with a significant medical history of he has got HRF that is the left ventricular ejection fraction is only 27%. He's got type 2 diabetes mellitus and his A1C is 7.2%, reasonably good. At the age of 64, 7.2 is very good. And he's got hypertension and his pressure is 136 bar 84 millimeters of mercury. It's good. And he's got stage 3B DKD. See, all the time try to classify the either the chronic kidney disease or the diabetic kidney disease not by just seeing the creatinine. You calculate the estimated glomerular filtration rate all the time, and you classify it into 1, 2, 3, A, B, 4 and 5. 5 is nothing but the end stage renal disease or the end stage kidney disease. So one is the stage of USCR where see, if you classify according to the estimated glomerular filtration rate, it is easy to classify and easy to treat. Say what drugs to be used and what not to be used becomes very easy if we can classify according to the EGFR. Say stage 3 B means, see, anything of EGFR from 30 to 44 is called stage 3B, and 45 to 59 is stage 3A, and the second stage is from 60 to 89 of the ml per minute of EGFR, and above 90 is stage 1, and normal is set as 120 ml of 120 ml per minute of EGFR is supposed to be the normal, and stage 4 is anything below the 29 to the 15 is stage 4, and anything that is around 15 or below 15 is called the end stage renal disease. So this patient is in stage 3 chronic kidney disease. The baseline EGFR is 38 ml per minute per 1.3 meter square of surface body area, and the potassium is 5 milliequivalents per liter, and this is mildly elevated. And the latest classification of the hyperkalemia is was introduced in the year 2019, and you from 5 to 5.5 it is mild hyperkalemia, and 5.2 5.5 to 6 is the moderate hyperkalemia, and anything beyond 6 milli equivalent per liter is defined as severe hyperkalemia. So this patient is in the mild hyperkalemia, and dyslipidemia is very good. The LDLC is around 55 milligram per deciliter, and his BMI is 36.8, and his home medication include the sacubitril valsartan. That's what I said, 49 plus 51, that is 100 milligram of the sacubitril valsartan twice a day, and metoprolol succinate 150 milligram a day, that is a beta blocker, and he is on a loop diuretic torsemide 20 mg a day, and statin rosuvastatin 20 milligram daily, aspirin 81 milligram daily. See, in our scenario we use only 75, but in the American and the Western scenario they use 81 or 162. We don't have that the 75. They don't have 75 150. We don't have likewise 81 and 162. Probably the case presentation is taken from an American scenario. And the metformin is 1000 milligram a day, and glipizide extended release 20 milligram a day. We generally don't find 20 milligram preparation in our scenario. See, maybe because of the body mass index, we have got only the 10 milligram, like we have the glipizide, the brand from USV, we have the Glynaze XL 10 milligram, 5 milligram and 10 milligram. They have 20 milligram. Like the physical examination shows, the heart rate is 70 beats per minute, and jugular venous pressure. Let us go back to our physiology days. Actually, one should remember always how to measure the JVP, that is the jugular venous pressure. The patient in the 45-degree angle, and the normal, the JVP is defined as the normal mean GBP is determined as the vertical distance above the midpoint of the right atrium, which is usually in between 6 to 8 centimeters per water. That is 6 to 8 is normal. So this patient has got a pressure of 8. So that is normal, and less than 5 it is seen in hypovolemia. That means if the pressure is less than 5, the patient is in hypovolemia, and if the patient has got a figure of more than 9, it is the impaired cardiac filling. That's what. So it has got, you all know that it has got some positive waves. The A, C and B are the positive waves, and it has got the negative waves, X wave to start with, and X descent and Y descent. So this is all physiology. We cannot forget the fundamentals throughout our life. As long as we remain clinicians, we need to be like thorough with the clinical examination, and nowadays clinical examination has no role to do with. We are all totally addicted or dependent on the investigations. For example, to tell you very honestly, the diagnosis of heart failure sometimes is very difficult to diagnose it with the clinical examinations. See, it was very difficult until William Harvey they explained the entire total circulation of blood and heart. William Harvey way back in 1628. Until then, the heart was something like an algebra. It was something a miraculous magic Pandora box. Nobody used to understand what the heart is unless William Harvey came into the scene. So when the Ian Thoven in 1890, when he discovered the electrocardiography, then the diagnosis has become much improved as far as the cardiovascular diseases. To tell you, my dear friends, just by seeing one ECG, you can make out 144 diseases or disorders of the heart. See, and after the Ranjan, has discovered this particular the X-rays way back in the 1895, and until then the imaging was very poor, and even till today we need to depend on the ECG. We need to depend on the imaging technologies, starting from the X-ray and the 2D echocardiography and the nuclear imaging and the cardiac catheterization, so and so, for the diagnosis of heart failure. But as a rule of thumb, we need to be very thorough with the clinical examination. What we were taught in our the third year, that is the first clinical year, the Hutchison's clinical methods, what it describes. It is our Gita, it is our Bible, it is our Quran. So, and he had got bilateral pedal edema. And the question is, would you consider an SGLT2 inhibitor for this patient? If it is yes, which SGLT2 would you prefer? And coming to the role of dapagliflozin in the heart failure management actually. So the flow chart given here shows the SGLT2 inhibition. On the one hand it leads to glycosuria, on the other hand it leads to natriuresis and osmotic diuresis. You should remember the mechanism of action of the SGLT2 inhibition actually. That leads to natriuresis and it has got some osmotic diuresis effect also. So on the right hand side you see this particular the glycosuria, which leads to the reduced insulin and the increased glucagon on one hand, and on the other hand the increased calorie removal, that is the glucose being excreted through the urine and the improved glycemic control and the reduced insulin and increased glucagon, automatically that leads to lipolysis, and which leads to ketosis on the one hand, and on the other hand all the factors, the increased calorie removal and all the improved glycemic control, they lead to weight loss. And the ketosis again leads to this particular the improved myocardial energetics, with, and the SGLT2 inhibition is associated with the reduced the proximal convoluted tubule oxygen demand, and that leads to reduced relative ischemia of the renal cortex, that leads to the increased erythropoietin production, which leads to increased hemoglobin and the hematocrit, which the ketosis and the increased HB and hematocrit eventually lead to improved myocardial energetics, which leads to the improved cardiovascular outcomes on the one hand. On the other hand, the off-target effects of SGLT2 inhibitors, that is inhibition of the cardiac SGLT1 and the NHE1, that NHE1 is nothing but sodium hydrogen exchanger, the subtype 1, that is that leads to improved cardiac calcium handling, which leads to the improved cardiovascular outcomes. And on the other hand, it leads to the SGLT2 inhibition leads to natriuresis and osmotic diuresis, which leads to the increased tubuloglomerular feedback, which leads to the selective afferent anteriolar constriction, and I'm sorry, let me put my mobile on flight mode, okay. And the selective afferent arteriolar constriction leads to reduced transglomerular pressure, leads to reduced proteinuria and the preserved renal function. And on the other hand, the natriuresis and the osmotic diuresis leads to the reduced blood pressure on the one hand and the reduced intravascular volume. And on the other hand, it increases the electrolyte free water clearance, which leads to the efficient interstitial fluid removal. And the reduced blood pressure and the reduced intravascular volume, they reduce the afterload and they reduce the preload, which improves the ventricular loading. And ultimately, these are all the factors. It's a multi-pronged the mechanisms of SGLT2 inhibition, which add to the improved cardiovascular outcomes. The glucose lowering effect of SGLT2 inhibitors is independent of the pancreatic beta cell function and insulin sensitivity, an ideal property of the context of type 2 diabetes disease progression. So let's move on to the recent clinical updates of dapagliflozin in heart failure. So let us get into the research and the backup of this particular dapagliflozin, backed up by the studies, especially the DAPA-HF and the delivers. This all the graphic representation, the curves show the DAPA-HF and the deliver results pulled from meta-analysis. It is divided into like cardiovascular, the endpoints are cardiovascular death, all-cause death, and total hospitalization for heart failure. The first hospitalization for heart failure, the cardiovascular death MIR stroke, the cardiovascular death RHF. See, the dapagliflozin reduced the risk of death from cardiovascular causes and hospital admissions for heart failure. If you observe this, all the six the graphic representations, where the red line is the placebo and the blue line is the dapagliflozin. You can see very clearly all the six parameters, what we take, the CV death, all-cause death, and the total hospitalization for HHF, that's called. The first hospitalization for HF or CV death or MIR stroke, CV death or the heart failure. You can see the curves getting separated from the beginning, and you find a clear spot between the placebo and the subsection of patients who are on dapagliflozin. So the inference that is that the dapagliflozin usage in this the heart failure, the DAPA-HF and the deliver trials, that shows that very quite evidently shows that the dapagliflozin reduce the risk of death from the cardiovascular causes and the hospital admissions for heart failure, that is HHF, hospitalization for heart failure. And the time to the clinical benefit of dapagliflozin, it means after how many days you see the clinical effects of dapagliflozin on the heart. So on the left hand side, the worsening of heart failure or the cardiovascular death, the left hand side we see the DAPA-HF trial, and on the right hand side we see the DELIVER trial. And the x-axis and the y-axis we see the dapagliflozin versus placebo, and the days, it is from day 0 to day 100 as far as DAPA-HF is concerned, and they say the day 0 to day 30 in case of DELIVER trial actually. So if you observe, the risk reduction was rapidly apparent. The patients who are on dapagliflozin in DAPA-HF trial, specifically the statistical difference significance of this benefit was sustained by 28th day after randomization. You can clearly see the spurt. You got the 28th day itself, you have got the p-value of 0.3, that is 0.03, that is statistically significant. Though not very statistically significant, it is definitely significant. So coming to this DELIVER trial, it is as early as the first nominal statistical significance for worsening heart failure events was reached and sustained at the day 16 after randomization. You can see the arrow showing in both the DAPA-HF trial and the DELIVER trial the time taken for dapagliflozin to show the clinical effects. So it shows within a month you find the change as shown in DAPA-HF trial, which is a landmark trial, and the second landmark trial is DAPA-CKD. These are the two greatest trials done in the in context to dapagliflozin with regards to the heart failure and the chronic kidney disease. And the DELIVER trial had shown the nominal the statistical significance even on the day 16 itself. So it has got very early in onset, and if you continue the molecule, see the greatest advantage of the dapagliflozin or the empagliflozin we talked about the 4 standardized pillar treatment for heart failure, that is the SGLT2 inhibitors and the ARNI and the beta blockers and the MRA, that is the non-steroidal mineralocorticoid receptor antagonist. All the drugs, either the RNA has to be down titrated or up titrated. See, if it is a case of there is some sort of kidney impairment, you need to reduce the dose of RNA, because RNA itself also impairs the kidney function. That is one of the side effects of this particular sacubitril valsartan combination, the RNA. So if you take the beta blockers, either you whatever the beta blocker use, we generally go for the highly selective beta blockers like the bisoprolol, like the nebivolol, like the metoprolol. So you always you need to be very careful, and you need to watch for the heart rate, because the sinus tachycardia should be avoided, as well as the sinus bradycardia should be avoided. See, usually the heart rate is lessened with this beta blockers, and beyond a point you are not supposed to go down in heart failure as far as the heart rate is concerned in heart failure. So you need to all the time keep an eye on the RNA and the beta blockers, and also the mineralocorticoid receptor antagonists with regards to the electrolyte imbalances. The only one you can trust, happily start with 10 mg. You don't need to watch, you don't need to observe, you don't need to monitor, you don't need to titrate. No up titration, no down titration, is only the SGLT2 inhibition. That is the empagliflozin and the dapagliflozin. So the all other 3 molecules have to be monitored very closely. so as to not to allow the patient to get into some sort of disturbances, either the electrolyte disturbance or the heart rate disturbances or the worsening of the kidney function, or so many things you need to keep an eye. So this is the greatest advantage of the dapagliflozin. And this is the clinical outcomes in cardiorenal metabolic overlap. So the right hand side you find the graph. So you find the light to dark red, the 0 CRM, that is cardiorenal metabolic conditions, and 1 CRM and 2 CRM and 3 CRM, and you find to the left hand side that favors the dapagliflozin, and to the right hand side that favors the placebo. You can very clearly see the center of this particular slide. You can see everything is favoring the primary composite outcome or the composite of cardiovascular death and the recurrence of heart failure events. Everything is favoring dapagliflozin, and this is the post-hoc analysis of DELIVER trial. Actually, the relative benefits of dapagliflozin on the primary composite outcome, the cardiovascular death and worsening of heart failure, were consistent irrespective of the number of the cardiorenal metabolic conditions at baseline, and similar findings were observed for the individual components of the primary outcomes and for other outcomes. And effect of dapagliflozin on diuretic utilization in the heart failure with preserved ejection fraction. This is the pre-specified analysis of the DELIVER trial, and you can see the time to loop diuretic initiation among the patients not on loop diuretics at baseline. You can see it on the left hand side, and the right hand side graph shows the mean loop diuretic dose over the time. The left hand side, the inference is all the time it's the same. The placebo is the blue and the dapagliflozin is in the red graphic representation, and you can clearly see the spurt and the curves getting separated soon. From the beginning, the dapagliflozin reduced the new initiation of loop diuretics by 32%. Actually, it is very statistically significant. And with the right hand side, the treatment with dapagliflozin significantly attenuated the rate of the rise in loop diuretic dose relative to placebo, resulting in a mean dose reduction of the loop diuretic over a time of 2.5 milligram per year. That is a very significant finding that leads to reductions in the loop diuretics. Loop diuretics are not a choice, definitely. So we talked about the 4 pillars. So we talked about the indications of loop diuretics also in the beginning. And this slide shows the meta-analysis results of the phase 3 randomized control trials. 5 trials were included in the final analysis, and the efficacy outcomes is 11.2% reduction in the risk of all-cause death. That is, dapagliflozin was associated with a significantly reduced all-cause death and was safe concerning urinary tract infection, bone fracture, amputation and acute kidney injury compared to the with the placebo. And coming to the safety outcomes on the right hand side, no statistically significant difference in the urinary tract infection, bone fracture and amputation were found, and significant reduction in the acute kidney injury was observed. Actually, these are all the favorable effects with this particular the 5 randomized control trials done with the dapagliflozin. And this slide shows the DAPA response in acute heart failure study. The dapagliflozin may provide symptomatic relief and may improve the diuresis in patients with acute heart failure. It's a randomized double-blind study that included 87 patients with acute heart failure presenting with dyspnea, and within 24 hours of admission, the patients were randomized to receive either dapagliflozin 10 mg a day and or the placebo for 30 days. And on the right hand side, you can very clearly see the area under curve of the visual analog scale. The VAS is AUC is area under the curve, and the VAS is nothing but a visual analog scale. And then the bar diagrams you can see, the dark blue is, navy blue is the dapagliflozin bar, and the pink is the placebo. You definitely see the statistical difference between this the placebo and the dapagliflozin as far as the AUC of VAS dyspnea score. And the second thing is the same the significant statistical difference you can find the NT-proBNP change from the baseline. And last is the cumulative urine output, that is the ml, that is 13,700 ml was increased to the placebo was, and the dapagliflozin group the urine output was 18,600 ml. See, these are all the positive effects of this particular dapagliflozin in the setting of acute heart failure in the first 30 days compared with placebo. So the dapagliflozin significantly reduced the area under the curve of the visual analog scale dyspnea score, and the relative change in the NT-proBNP compared to its baseline, and had a higher cumulative urine output at day 4 than the placebo. And the preserved heart failure trial, the effects of dapagliflozin, biomarkers, symptoms and functional status of heart failure with preserved ejection fraction, and 289 patients symptomatic from HF2 ejection fraction of around or more than 45 were taken. And on the left hand side you can see the 12-week change in the walking distance. This is the walking distance and the walking test actually. So 6-meter walking test or the 12-week change in the walking test. You can clearly see the DAPA is in the orange and the placebo in the navy blue. You can see the deterioration of around or more than 15 meters, or no change in the middle bar diagram shows no change, or the last one which shows the change in the improvement of around or more than 15 meters. You can clearly say that the more patients treated with dapagliflozin meaningfully improved walking distance and fewer experienced walking distance deterioration compared to the placebo. And on the right hand side you can see the 6-minute walk distance test, that is 6 MWT. So the outcome is patients randomized to dapagliflozin were more likely to experience a clinically meaningful improvement in 6-meter walk test distance at week 12, and were less likely than placebo treated patients to experience a 15-meter reduction in the 6-meter walk test distance. And the cardio and metabolic effects of dapagliflozin in heart failure with the preserved ejection fraction. This is called the Cameo DAPA trial actually. Cardio and metabolic effects of dapagliflozin, that is Cameo DAPA trial. It's a single center double-blinded randomized placebo controlled trial testing the effects of 10 mg of dapagliflozin once daily in 37 patients with HPEF. Actually, it has shown like estimated treatment difference, that is the ETD at 24 weeks relative to the treatment with the placebo. So you can very clearly see the reduction in the pulmonary capillary wedge pressure at rest and at maximal exercise also. The p-value is statistically significant in both the cases. And coming down to the right hand the reduction in the body weight, the p-value is, the reduction is by 3.5 kilos, and the reduction in the plasma volume, that is by 285 ml, which are statistically significant. And the inference is the patients with the heart failure with preserved ejection fraction, treatment with dapagliflozin reduces the resting and the exercise reductions in the pulmonary capillary wedge pressure, along with the favorable effects of the plasma volume and the body weight. And dapagliflozin effects on the cardiometabolic outcomes in patients with acute heart attack, that is DAPA-MI. And the primary outcome, the international registry based randomized double blind control, which included 4,000 odd patients without prior diabetes or chronic heart failure presenting with acute MI and impaired left ventricular systolic function. The primary outcome, the hierarchical composite of death, hospitalization for heart failure, non-fatal MI, atrial fibrillation or flutter, type 2 diabetes, and the NYHA functional classification at the last visit, and the body weight decreased of 5% or greater at the last visit during the win ratio analysis method, which shows that the dapagliflozin demonstrated significantly more wins than the placebo. The dapagliflozin demonstrated significant benefits with regards to the improvement in cardiometabolic outcomes after approximately 1 year of treatment with dapagliflozin 10 milligram. And the impact of dapagliflozin on cardiac remodeling in patients with chronic heart failure, this is called the DAPA-MODA study. So it is nothing but the DAPA-MODA study. It was a multi-center, single-arm, open-label prospective study that demonstrated the associations between the dapagliflozin use and the reduction of cardiac volumes as well as the cardiac biomarkers like NT-proBNP in a cohort of 162 patients which were taken into the DAPA-MODA study. The stable chronic heart patients where the 21.6% were diabetics. However, the study observations were limited by the lack of control group. This is the pitfall of this DAPA-MODA study. It had no control arm. That's, and taken all together, actually there is the conflicting evidence regarding the association between the dapagliflozin and the cardiac biomarkers and the cardiac remodeling in patients with heart failure and the type 2 diabetes. Therefore, the aim of the present study was to examine the associations utilizing the real world data. So this is regarding the DAPA-MODA study. So we'll see what is given in this slide. So 162 patients, as I said, with the 52% of the patients had the left ventricular ejection fraction of more than 40%. That is almost, you can take it as with like roughly the preserved ejection fraction. So the changes in the echocardiographic parameters baseline versus 180 days, that is, this is to see whether the left atrium volume index is reduced or not. And I said it was a little bit controversial study. It has got some pitfalls. It's inconsistent. We cannot confidently say that it was able to reduce the left atrial volume index at 180 days as the study claims. Actually, you can clearly see that the dapagliflozin demonstrated a significant reduction in left atrial volume index at 180 days, primarily due to a decrease in the reservoir volume. This is not an effect of dapagliflozin per se in DAPA-MODA study. It is a conflicting result actually. So we should compare it with the real world scenario. So the cost effectiveness of dapagliflozin in cases of the heart failure with reduced ejection fraction, and the Markov model to estimate the cost effectiveness of dapagliflozin standard of care, empagliflozin standard of care, and standard of care alone. And costs were measured in 2022 US dollars, and effectiveness was measured in quality adjusted life years, that is, we call it QALY, that is quality adjusted life years, from randomized control trials actually. And the ICER, that is the incremental cost effectiveness ratios compared with the standard of care alone, that is the dapagliflozin standard of care. We see the amount like the USD 56,782 per QALY, when compared with the empagliflozin standard of care, that is USD 89,258 per quali. So the dapagliflozin SOC cost more, the 5,524, but yielded more than 0.20 qualis than the empagliflozin standard of care, with the ICER of 27,860 US dollars per quali, and the dapagliflozin standard of care was cost effective versus the empagliflozin standard of care, or standard of care alone for treatment of the heart failure with reduced ejection fraction. And the effectiveness of dapagliflozin in the incidence of atrial fibrillation and flutter. Dapagliflozin is effective in reducing the incidence of both the flutter and the atrial fibrillation significantly. And effect of dapagliflozin on quality of life, QOL. The participant level pooled analysis from DAPA, HF and the delivered trials. Actually, these are all the satisfaction questionnaires. The KCCQ is nothing but Kansas City Cardiomyopathy questionnaire, and the TSS is nothing but the total symptom score. And there are other terms also, like the clinical summary score is called CSS, that is KCCQ CSS, the KCCQ TSS, that is total symptom score. The KCCQ CSS is the clinical summary scores, and the KCCQ OSS, that is overall summary score. So the finally the greater proportion of the patients they randomized to the dapagliflozin experienced a large, that is more around or more than 15-point increase improvements in the KCCQ total symptom score by 8 months post randomization. And what is what the future holds? So that is, what about the future trials with dapagliflozin with regards to heart failure, which are in the pipeline? You can see the 5 trials are under the pipeline, and you can go through the table. It's a busy slide actually. You can see there are 5 studies ongoing, and the conditions and the study name, the phase of the study, and the number of patients included, and the current status. So we have got the multiple trials going on, and we are supposed to expect the trials by the end of 2024 or the end of some are expected at the 25 the year end, or some are supposed to roll out in the year 2026. These are all the studies done with the dapagliflozin 10 mg with regards to heart failure studies, that is heart failure with reduced ejection fraction, and acute decompensated heart failure, acute heart failure, anemia heart failure, that is Adidas trial, and acute heart failure, that is CODA HRF trial. And these several trials, that is the starting from ICAR to Empathy to the DAPA ACT, the HF TIMI 68, and the Adidas, and the CODA heart failure with reduced ejection fraction are yet to be rolled out. They are still the ongoing studies which are in the pipeline. And now we have come to the last and very important part of our this thing, and the summary, that is the take home message actually. So the SGLT2 inhibitors are recommended across the spectrum of the heart failure, that is with heart failure with reduced ejection fraction, heart failure with mildly reduced ejection fraction, and heart failure with preserved ejection fraction. This is the take home message. And one more thing I would like to add here is that we have the one large study showed thousands of patients. That's a very large study, included lakhs and lakhs of people, which has shown very clearly that there is the incremental benefit of the left ventricular ejection fraction by 10 points. That's what I said. the heart failure with the improved ejection fraction. So that is also one of the greatest take-home messages for this dapagliflozin. That is, we start dapagliflozin 10 milligram in the HRF patients where it is less than or around 40 milligram, 40% of the LVEF, and the patient improves to 50, or from 30 to 40, or from 35 to 45. That is called the heart failure with improved ejection fraction. And the dapagliflozin decreases the rates of the cardiovascular death or worsening of heart failure and all-cause mortality. And the dapagliflozin improves the quality of life across the all spectrum of heart failure, which we have seen by the KCCQ, the total symptom score. See, with this, my session is over, and once again I thank all my professional colleagues for your patient listening. And we have definitely today we have talked about the entire cardiology, not the endocrine part or the diabetes part. But I am glad to deliver this lecture. I don't know whether the people have given it by fault or my funda is only one thing. Whatever is given, that I have to deliver. That's it. Okay. Whether it's an endocrine the subject, or whether it's a cardiology subject, or it's a nephrology subject, whatever it is, our molecule is the same, the dapagliflozin with multi-pronged approach. That is the reason why we call this SGLT2 inhibitors or the gliflozins the latest pleiotropic drugs of this particular the entire era. See, especially not the canagliflozin, barring canagliflozin, the DAPA and the EMPA only. I am referring to DAPA and EMPA, and even the US FDA has given approval to DAPA and EMPA to be used in the absence of diabetes, not the CANA, please. Yeah, any questions? I am glad to take the questions. Chaitanya, are there any questions, please?
There is one question right there.
Oh, dear Rajdeep, wonderful to see Rajdeep. Yeah, tell me, Rajdeep.
Yes, your experience on the ARN related hypertension. Your take.
Which one?
ARN related hypertension.
RNI related hypertension.
Yeah, RN related hypertension.
Yeah, definitely that is the one of the side effects. The mechanism of action is that reduces the pressure actually. RNI reduces the pressure because it has got both sacubitril and the valsartan. Sacubitril per se that sends out the sodium from the body. So apart from the sodium also the water moves out of the body where the volume goes down, which leads to the lowered blood pressure, hypotension. And one more thing is the patient tends to pee more, that is he passes lot of urine after taking the sacubitril molecule per se. It is the mechanism of action of sacubitril that the pressures go down. On top of it, the addition of valsartan being a potent the antihypertensive agent, that is dose dependent actually. That is less seen with the 50 milligram and more seen with the 100 milligram, and it is quite evident that is the reason I said you need to watch for all the disturbances with all these, the RNA or the beta blockers or the non-steroidal mineralocorticoid receptor antagonists, except the dapagliflozin or the empagliflozin, only wherein you need to just relax and watch. 10 mg of dapagliflozin, 25 mg of empagliflozin. You can just wait and watch. All others have to be monitored for hypotension. Even the bradycardia, they reduced the heart rate and all, and the electrolyte disturbance. You got the answer, Rajdeep?
Yeah, I got the answer. Why I asked this question affects to DAPA, because this also gets rid of more of water from the.
Yeah, definitely. It has got a natriuretic effect as well as the osmotic diuretic effect. These are all the favoring points for heart failure, Rajdeep, actually. So that is the reason why I said you need to have a close watch on this RNI, the four pillars of medical management. You need to be very careful with regard. You need a tight watch on the blood pressures. and the electrolytes, the potassium and the serum creatinine, the kidney parameters have to be monitored very frequently when the patient is on this RNA, because RNA itself can damage, the sacubitril itself can damage the kidney function by reducing the EGFR.
Secondly, I think you answered about the SGLT2 inhibitor. I think if it is below 45, we need to be cautious about giving the SGLT2 inhibitor. Am I right?
Absolutely. See, it is an indication. It is an indication even in the heart failure, the dapagliflozin or the empagliflozin should be added to the patients who have got the left ventricular ejection fraction around or less than 45, or per se I say the frank heart failure with reduced ejection fraction less than 40, it is indicated. Only thing is we need to reduce the dose of RNA. We generally start with only 50 milligram. We never go to 100 or 200 in the cases of HRF, that is heart failure with reduced ejection fraction. We need to be very cautious with RNA as far as this particular heart failure with reduced ejection fraction, that is in left ventricular LVEF of around or less than 40%, Razdeep. So we need to be very cautious in deciding the dose based on the left ventricular ejection fraction. That is very important take home message. See, where you don't require the dose titration is the SGLT2 inhibition part only, whereas others have to be monitored very closely.
Okay, but in isolation, if we are giving dapagliflozin only, so if it is below 45, we don't need to start SGLT2. Am I right?
You can still improve that. They say dapagliflozin improves the left ventricular ejection fraction definitely.
Okay.
Now all the international the societies, see per se I tell you, starting from the American College of Cardiology Foundation, bar American Heart Association, bar the North America the Heart Association, and even the European Association for the Heart Failure by the European Society of Cardiology, and even the Japanese Association for Heart Failure. These are all the major the heart failure bodies internationally. They have a common consensus. They all have come to one platform in 2020, and they decided to add this particular dapagliflozin or empagliflozin to all classes of the take-home message. That's what I said. The SGLT2 inhibitors, the dapagliflozin 10 milligram and the empagliflozin 25 milligram is a mandatory addition to the HRF, or with the heart failure with reduced the mildly reduced ejection fraction, or the HPF, that is the preserved ejection fraction. All the subsets are benefited by addition of this particular SGLT2 inhibitors. So whatever be the ejection fraction, you just add dapagliflozin to the standard care of treatment. That is from 2015 onwards we started using the Vimada, the RNA, and even prior to that we used to use beta blockers. And the initial the basic prills that were used is that enalapril was used. That was a landmark trial, I said. Now the funda is from those who cannot afford to go for. Now it is off patented, Rajdeep. Now it is off patented. RNA is off patented and it is available at a very affordable price. Very affordable price. Even the 50 milligram also is to be given like half and half in like reduced ejection fraction, where there is the LVEF is less than 40. We need to be cautious. Even the 50 mg has to be down titrated to 25 BD, and then you can slowly seeing the symptoms and all, seeing the EGFR, seeing the pressure, blood pressure, and seeing the heart rate and all these parameters, and seeing the metabolic disturbances. you can slowly increase it to 50 mg BD, and when the LVEF starts raising by 10 points, which I said it is a subset called the left ventricular the ejection fraction the improvement by 10 points is called the heart failure with improved ejection fraction. So based on that, so we can slowly increase the dose of ARNI to 100 milligram BD, or even we can go to 200 milligram BD. And one more thing in this context I would like to, if at all one wants to stop the already existing either ACE inhibitor, or the doctor might have put him on this even prior to this 2015 scenario, ARB or AC, either ARB or AC inhibitor, they want to switch over to this. The doctor feels that okay, that there is no statistical symptomatic improvement, so let us move on to ARNI and we discard this particular the AC inhibitor or ARB, we go to the ARNI. Then that is the only one take home message I would like to give is, all the time when you switch over to ARNI from an AC inhibitor or ARB, you have to leave an interval of 36 hours. That is by default, because the effect of AC inhibitor or ARB should vanish off before the ARNI takes off that. And second thing is, if you don't give the gap of 36 hours, that is 1.5 days gap, there is every possibility that the patient may develop the angioedema, which is a rare phenomenon, but you have to keep it in mind, which is very lethal to the patient.
Excellent.
Is it clear, Rasdeep? You want some more explanation?
No, it is excellent. The last one is excellent. But,
Yeah, that's it. Like we from human insulin we change to the analogs and all. So that is 1:1 ratio. That nothing to worry about. When from IV to AC we change, we have some protocol, ICU settings. Likewise, when the patient is on AC or ARB, the doctor feels, the cardiologist feels that the patient has to be on ARNI as there is no improvement, because keeping the benefits of sacubitril and valsartan fixed dose combination. So 36-hour interval is mandatory. That is one take home message. See, whenever Rajdeep is there, you know the answer, but to enlighten the other participants, you question me. I know that, Rajdeep. Very good, wonderful.
No, I wanted to update myself.
Don't bluff, okay?
Because I don't want to go through the ADA guidelines, because that confuses me. One more question.
Yeah, tell me, Rajdeep. Yeah.
One very small question. It's
Yeah.
a very low-tech question. You covered excellently about the high-tech issue related to heart failure.
Uh-huh.
One very low-tech question is,
Yeah.
how often do you send the patient
Ah.
for FOA, FOB, homocysteine level and IL-6 level, the inflammatory markers for the cardiovascular disease?
Very. See, we go for HSCRP, we go for NT-proBNP. That's it. Only these are the two cardiac markers we monitor on regular basis. And what you said is rarest of the rare. This is my personal experience with heart failure. And to be honest with you, I told you the DAPA MODA study also, what they claim is not true actually. They claim that dapagliflozin was able to reduce the left atrial volume index, but that is a conflicting the scenario wherein there is no control group. The study has got some pitfalls, and we cannot wholeheartedly I cannot say that the Reddy people have asked me to be the speaker of this particular cardiology topic. I cannot say everything is yes with dapagliflozin. Where there are pitfalls, I need to point out, certainly.
So that means the take-home message is you don't prefer doing IS-6 and homocysteine level. Am I right?
Generally not. Like C-peptide and all insulin the fasting insulin and all in diabetes. I said I had never ordered even one single C-peptide in my entire 33 years of experience, Rajdeep. I've told you.
Yeah, yeah.
And even the latest ADA 2024 guidelines, you don't find any role of C-peptide. If you find, you can tell me.
So, I was reading somewhere
Uh-huh.
that C-peptide index in the postprandial time.
Ah.
It gives you a good idea about the insulin capacity of a
That is definitely true. Theoretically, that is 100% true. But when it comes to practice, it is because of the poverty. It is because of the tests are very costly that we cannot order to a common man actually. For an affordable patient, you can order anything, Rajdeep.
But my question is then why do we give it theoretical answer? No, we have to come to the practical guidelines, right?
Yeah.
See, then we should not be mentioning in the guidelines about the C-peptide index.
See, for either type 1 or for the 1.5, that is LADA, they never had mentioned anything in the latest ADA guidelines 2024 per se, except the blood sugars. That's it. Am I true? Am I correct? Correct me if it is wrong. Okay.
Yeah, that's true. Thank you. I was trying to get to the practical answer because it is being said, what is being said, it should not be practiced also.
Absolutely. See, lot of things. I've closely observed the ADA, which is totally different. ADA is totally different. What it says, it doesn't follow. What it doesn't say, it follows. See, the inclusion of the HbA1c as one of the diagnostic criteria for the diagnosis of diabetes. I was one of the principal investigators from the country actually. So 20 countries participated with multiple principal investigators. The chairman being Professor David Nathan, and the main principal investigator was Vivian Fonseca from USA. Both. The Vivian Fonseca, he is originally a Goan, our own Indian origin, but born and brought up in US. He is the professor of medicine and endocrinology in the Tulane University actually. So when 19 countries opposed inclusion of HbA1c is irrational unless otherwise the procedure is standardized all over the globe, then they bluntly refused. They just had included. I don't know exactly the year 2010 or 2012, 12 I think, 2012. All of a sudden they have included in the after the ADA sessions are over. So I was sitting on the dais actually. We were strongly opposing. Everybody was opposing. So we get the multiple reports for the same patient at the same point of time. The blood is drawn. You get multiple A1C reports. See, I did it in the practically to show Professor David Nathan. I went to the stalls. I asked him, "Is it standardized in the United States?" First of all, he said 100% standardized. I went to the stalls, exhibits in the lunch break. I had given 3 samples of mine. See, all were totally different. One was 5.1, ranging from 6.7. So I took the slips and I went chasing David Nathan. When I had shown him, he simply laughed. Mohan, forget about it. See, this is the attitude of ADA.
It's really funny.
I can never forget this incident. See, 19 countries, the principal investigators opposing the A1C being included as the one of the diagnosis. Already we have got enough criteria. We have got 3 criteria, right? Okay. The fasting plasma we have, the random we have, the OGTT we have. Then why should you need this? This is only a prognostic tool. And one thing, I want to make one thing very clear. Just by A1C we cannot start the treatment. That's what ADA says. Then why do you want to include it in the diagnostic criteria? See, we just write the type 2 diabetes by A1C. As fasting and post lunch blood sugars are normal, only lifestyle modification is indicated. It says never treat. Even metformin is not indicated for a patient who has got an A1C level of 7.9, the fasting plasma glucose of 75 and post lunch 130. So no treatment, only lifestyle modification. But the diagnosis is made by A1C, he is diabetic. Anything around